I'm using the arrows. Okay, which arrow? This? Okay. So most HPV infections fortunately resolve spontaneously. They rarely persist. And if they persist, it takes them 10 to 30 years to cause invasive cancer. So this long natural history is a good opportunity for us to prevent the disease, either by primary or secondary prevention. So everybody talked about incidence and mortality. So yeah, it's very high. There are more than 500,000 cases of cervical cancer every year. Out of these 300,000 deaths worldwide, and 85% of those occur in the low and middle income countries, but not us. I'll show you why. Look at this map. So, you know, when everybody talks about cervical cancer, they say, yeah, this is a disease of poorly developed or undeveloped countries. And we are included, yes, in those, you know, developing countries. But look at this map. See, the dark colors are where the disease is high. The light colors, here is my arrow, let me see, is us. This is all us. Only 1 or 2 countries in North Africa, which belong to us, have high incidence rates. And we'll show. And this is the mortality, again, reflecting the same thing. Our mortality is like West Europe and Africa. But we have only a couple of countries in North Africa where the incidence is relatively higher. And here again, this is the world here. If you can see my arrow, the average for the world is 13 cases per 100,000, and the mortality is 6.9 per 100,000 women. However, look at West Asia, which is us, it's the lower incidence. So please, you will see why I don't really recommend vaccination at this point. I recommend the screening, but I'll show. And then we have North Africa, which is, I show you a couple of countries in North Africa, like, you know, Morocco, Algeria, but even those are even below the average of the world in incidence. Unfortunately, the mortality is slightly higher than other countries with similar incidence, like you can see Southern Europe or even higher. But that's, we have to improve on the treatment rather than other things. And as you can see, worldwide, cervical cancer is really number 4 worldwide. This is including all the 85% of that occurs in Africa and in Latin and South America. And you see, breast is really where you have to really invest your money. It's the number 1 in the world and in our country and in the Middle East as well. And here again, the world compared with EMRO. EMRO is the Eastern Mediterranean region of the WHO, which we belong to. And you can see it's number 4. That's, by the way, as you see here, estimated. Now, the WHO estimations are really higher than the usual. I'll show you why. Because they put Jordan, for example. These are the crude numbers of, and you can see the EMRO region have 15,000 cases and 8,000 deaths in one of those years. I don't know, this is probably 2018 or so. It's really much lower than any other part or region of the world. The only one here, the United States, 13,000 in incidence and 7. So we're similar. EMRO is similar to the US, which has all the screening things that were actually invented there. George Papanikolaou, the previous speaker, talked about, was in the US when he, yes, he's Greek, but he was a US trained and anyway. So why the high mortality? Because of late detection, because there is no screening, because lack of access for medical care in these countries. Not because it's more common, yes, but you can, if you can catch it and screen, you can do. These are the Arab countries. And you can see the US here at 6.8 and Jordan, I don't see Jordan here, yeah, 1.5. And that's actually overestimated. It's even less than 1.5. And other countries in the middle, in the area, more or less Egypt. You can see Algeria, I don't know why Algeria, but Morocco is even higher. It's not here on the list. So this is the 2016 cancer registry of Jordan showing the number of cases. And you can see the number of cases of cervix here. It's 39 cases in that year. And the years before that, it was 50. So it's hanging around 50, 60. The WHO says 100. I don't know where they got this number, but this is the Jordan Cancer Registry. Maybe they included all of the residents of Jordan because these are only Jordanians, 39 cases. And these are the 10 most common cancers among Jordanians, both genders. So the cervix cancer is not among those, okay? It's not among the most. And these are the most common cancers among Jordanian females, and it's not there. Okay, among females, it's breast, colorectal, and it's not even in this list, cervix. And these are the mortality due to cancer types, both genders in Jordan, and it's not in the list. It's with the others, all right? And this is just another year showing 44 cases of cancer cervix in Jordan. So yes, cervical cancer is the most common cancer among women in 45 countries of the world, and it kills more women than any other form of cancer in 55 countries of the world, but not in our region. This includes, of course, sub-Saharan Africa and many countries in Asia and Central and South America, as we said. And this was covered, you know, by all speakers before me and maybe the speakers after me. HPV is the cause, and it is the cause. Its cause is 99.9999% of cervical cancer. Two types, as everybody said, there are more than 100 types. Two types cause 70 or 75% in our case. These are 16 and 18 of cervical cancer. There are other types. I don't need to recover this. And this is the paper that I published and Dr. Abir Annab mentioned. We looked at the human papillomavirus types in invasive cancer in Jordan, and 16 and 18 were responsible for 75% of the cases. Most women infected with this high-risk HPV do not develop cancer. Actually, it's only a very tiny fraction. So of these, there would be, you know, about 10% will be persistent. And these 10% that persist, some of them actually will heal, and some of them will progress. And even the progressed lesion can reverse. And out of those that progress, only a very small fraction will, you know, go into invasive cancer. And this was shown previously in one of the previous speakers' talks. So HPV affects, you know, the basal cells. And if it is not a productive infection, in other words, produces infection, it becomes a persistent infection. Like here, it integrates into the tumor, into the DNA of the host cells, and 0.8% will develop cancer, invasive cancer. This is again more or less the time. So you can see this is the HPV infection. This is the precancerous lesions or the dysplasia, and this is the cancer itself, very low fraction. And as you can see, this is the healed, this is the persistent, and this is the cancer here, only a small fraction again. So where does it start? It starts in the transitional zone between the ectocervix and the endocervix. This is the transitional zone, this line. Of course, this is where the infection starts. So this is how it looks under the microscope. This is the normal, this is the basement membrane. And if the lower 1/3 of the normal mucosa is involved by dysplastic cells, we call this mild dysplasia or CIN1. And this is, of course, Abir covered this. So she covered my pathology as well. Thank you, Abir. So here, this is the moderate to severe precancer. It affects 2/3 up to 1 full thickness. And then after the 1 full thickness, which is the carcinoma in situ, it invades below the basement membrane, and that's an invasive carcinoma. And these are the cytological findings as well as the colposcopical findings. You can see the aceto-white here, and this is the high-grade dysplasia. And these are the coilocytes, characteristic pathologic findings in HPV infections, the coilocyte, it's called. And these are the high-grade dysplasia. This is the invasive carcinoma. These are cytologies. And this is the histology. This is the basement membrane. Now it's upside down. So this is HPV, this is normal. And this is, you have CIN1, where you have these small cells in the lower half. And this is full thickness involvement by dysplastic cells. This is the CIN3 or severe dysplasia or carcinoma in situ, more or less the same. And this is the invasive cervical cancer. It penetrates the basement membrane. So what are the cofactors for cervical carcinoma? The cofactors, in addition to HPV infection, there are other factors. The immune status of the patient. If they have HIV, they are likely to have more persistent infection. And this infection is actually more rapid to progress into precancer and cancer. Co-infection with other sexually transmitted diseases. Parity and young age at first birth. Tobacco smoking. The use of oral contraceptives for over 5 years. Prevention, the role of screening, already talked about, the Pap test. But anyway, I'm showing the effect now of this screening. So you can see the incidence in the US in 1975 and the mortality here. You can see the gradual decline. This is before the vaccine was ever invented. This is just because of the screening. So screening is very effective, and screening should and always remain. And these other countries of the world, even those countries that we now think of having a very high incidence, like Colombia here and Costa Rica, they also, before vaccination, implemented screening, and you can see the dramatic drop in incidence and mortality in these countries. So screening is very efficient before even the invention of the vaccine again. So this is the WHO approach for prevention as of 2014, I believe. So primary prevention, vaccination; secondary prevention, the screening; women above 30, that's where you should do. And tertiary prevention is the treatment of precancerous and cancerous lesions. So however, now I'm talking about the vaccine. Access, assess the affordability of the vaccine, cost effectiveness study, and sustainability of introducing HPV vaccine. The screen and treat approach actually is efficient and has been shown, documented, to produce the required effects. And you need a strong referral system if you want to implement the screening. So this is again another CDC ad showing how it drops. That's good for the US. What about Arab countries? Do we need to implement prevention? Yes. Vaccination, I'm not sure. I don't think so. Screening, yes. And this is the WHO recommendations for HPV vaccination. What it says, yeah, we should vaccinate. However, if cervical cancer or both, or other HPV-related diseases or both, constitute a public health priority. So as you have seen from 5 figures, it's not a public health priority. Now, vaccine introduction has to be programmatically feasible, and it should be sustainable. You need sustainability, and it should be cost effective. And I will show you that it's not cost effective. Abir, and I don't know who talked about a study from Iran. I'm not going to show or talk about that, but that was also something that I can add to my argument, the study from Iran, but I'm going to show you the studies from our data that was not published and from Lebanon. So the introduction of HPV vaccination here in this line should not undermine or divert funding from the development or maintenance of effective screening programs, and I vote for that. So why in Jordan, again, this I have shown this before, it's not among the causes of mortality, and that actually you can draw conclusion to all countries in the region except perhaps Morocco or Algeria. So we have an unpublished study from Jordan that actually the study about HPV that I talked about initially was for this cost effectiveness. We want first to see whether we do have HPV causing cervical cancer. Yes, we showed that. And then we studied the cost effectiveness. At that time, in 2006 or 7, the cost of the vaccination was several hundred times treating the 50 patients or so of cervical cancer per year in Jordan. But that at the start of the vaccine was very, expensive. Now probably it's cheaper, so I would say several, maybe tens of times rather than hundreds of times more costly. So this is a study that was just published in 2019 from Lebanon. And Lebanon probably has more HPV-related diseases than our situation, but that's fine. They wrote their conclusion that the cost analysis using limited available data indicates that massive HPV vaccination would not be cost beneficial under the circumstances existing in 2016. So these two studies from the area, ours, Lebanon, and the Iranian study that I didn't, talk about. Again, if I have time, and this is from a Tunisian website talking about HPV, and the previous speaker took some of the slides from this. And look at the misleading information. I'm sorry to say.
2 minutes, Dr. Zghair.
Yeah,
2 minutes.
okay.
Yeah. Thank you so much.
2 minutes, fine. It says cervical cancer is a leading cause of death in women within the Middle East. That's absolutely false. All right. And it can cause, anyway. And this is a map from their website and showing the number, and actually they're including Turkey and Iran, that's fine. And they say that there are 9,000 deaths. Yeah, 9,000 deaths. We're talking about 600 million people living in this area. So if you divide that, that's really a very minute fraction in comparison to breast cancer, for example. And you can see Morocco and Algeria have the highest in this. But this is from their website. And then there is another page on their website. Actually, the number is even less, 11,000 more incidents and 7,000 incidents. I mean, mortality. Anyway, so, well, the numbers here are estimations. They are all estimations. Even the WHO tells you that it's an estimated. And here you can see in Jordan 104 cases. I haven't seen 104 cases in Jordan, but perhaps they combined Jordanian and non-Jordanian. It might be that's the reason. So Algeria have higher numbers. Lebanon 192. Okay, Morocco has the highest number in the area. So maybe Morocco should adopt vaccination, perhaps, but they have to do cost effectiveness study. But that's the only exception for the entire Middle East region, in my opinion. And these are the forecasted numbers. So again, look at this. The second largest cancer killer of women in the region, absolutely false. It's not the second. I have shown you that it's probably the fourth or the fifth, according to the WHO, but that's overestimation. If you remove Morocco from that, it will be the number 10 or 9 in the region. Call to action, that's also from the area showing this. This was also shown by my previous speaker. Anyway, the numbers are really very, very low in comparison to the world. This is another Jordan Cancer Registry of the 10 cancers most common among Jordanian female in 2013. I showed you the 2016, and it's not among those 10. So screening recommendations have already been talked about. I don't have to show you again, but this is the summary of all. You could use HPV alone, high-risk HPV alone, but we should adopt screening. I vote for screening, whether it's opportunistic or more, structured type of screening, any type of screening, even once in 10 years for women above 30 that or of childbearing age, that would be good, in my opinion, rather than opportunistic screening. So this is also has been shown before. And this is the HPV using HPV screening. And this is from the New England Journal, saving the world's women from cervical cancer. Yes, but not to undermine screening. Thank you very much. That's it.
Thank you very much, Dr. Zahir. That's really very knowledgeable lecture presentation. Thanks a lot. I'm sure that there will be lots to discuss in the discussion session. Now we're moving to Dr. Mazen, Mr. Mazen Bishtawi, according to the English tradition. Mr. Mazen Bishtawi, I know him from more than 15 years ago. He used to train all the subspecialty trainees in medical hysterectomy for cervical cancer at Norfolk and Norwich Hospital. Is one of the pioneering centers in the UK in cervical cancer. So, Dr. Mazen, all yours. I'm really biased towards you, as you know, so there's lots of conflict of interest to declare here. All right, please start.
Thank you very much, Ahmed. Just waiting for Dr. Maher to log off the screen so I can start my presentation. I would like to thank the organizing committee, Dr. Suha and the team for inviting me for such a prestigious meeting. And I feel privileged to present after my previous colleagues. Yeah, I can share now. Thank you. So are we okay? You can see the screen?
Yeah, we can. Yes, we can.
Okay, so I'll talk about the management of cervical cancer in a broader perspective. And like my previous colleagues, I'll really concentrate more on the prevention. So I'd like to go a little bit more local about data from Jordan. I'll talk about the prevalence of cervical cancer. I'll talk about premalignant cervical lesions in Jordan. I'll talk about the prevention of cervical cancer, staging, fertility sparing surgery. I'll talk a little bit about types of radical hysterectomy and the role of minimal access surgery. The data has presented over and over, and most of my colleagues looked at the absolute figures of how common cervical cancer in Jordan. But if you look at the trend, there is a trend in cervical cancer. We used to have 23 cases in 2004, up to 40 cases in 2007, 50 cases in 2013, and in 2018, we have 104 cases. And I tend to believe these data because knowing the society and the changes within the society, you would expect an increment in cervical cancer. So it ranks number 21 in Jordan. And like what was presented before, it cannot be attributed to increase in the population of Jordan alone. So there has been an increase in cervical cancer. If you look at nearby countries, Oman, 14, Morocco, yeah, quite rightly very high. I've been in Morocco several times to talk about cervical cancer. In Sudan, it's number 5. In Lebanon, it's number 19. So yes, we are on the lower side of the cervical cancer, but would that continue? So the question is, do we really need to have a cervical screening program? Do we need to have a vaccination? I am not talking about the current movement. I think rather than being reactive to what's happening, we wanted to be proactive. So we wanted to see the projections. So are our incidence of cervical cancer going to be the same from now until the 5 years? So isn't it better to plan our health resources and planning for the future? So we're all in this together. Yes, we are in this region, but we are still in the same storm at different ships. So we have to navigate our ship to the safety zone. And I'd like to talk about the HPV more or less like a coronavirus. So the cervical cancer, it's a sexually transmitted disease, which means it's related to our behavior. The minute our behavior changes, the cervical cancer will go up and down. And that's why Jordan so far has been low on the incidence of cervical cancer. But would our behavior change? Same like a coronavirus, I think we would have an increment in cervical cancer. And again, if you ask those guys, do we need a cervical screening program? I can tell you the answer from now. No, the politician in Jordan will not agree any cervical screening program or any vaccination at this economic downturn. So let us focus about the knowledge in the general population. So what do women, our primary target, know about cervical cancer? And again, I like this slide, which was presented earlier by Dr. Maher. Yes, we have according to the time frame, you have an increase in HPV infection, followed by an increment few years by a precancerous lesion and then a cervical cancer. So if we can prove that there is an increase in HPV prevalence and precancerous lesions in our society, eventually in the coming 10 to 15 years, you are definitely going to have a higher numbers. So we're talking about the future, we're not talking about the current movement. I have published few studies about the cervical cancer. One of them is, as I looked at 15 years of data looking at abnormality in cervical cancer. And you can see that the L-cell has increased from the year 2000 to 2014. And L-cell is a mark of HPV infectivity. And if we have an increase in abnormal cervical cells, that means in the coming 10 and 15 years, definitely you are going to have an increment in cervical cancer. And again, we are like anybody else in the world. The HPV infectivity is for women less than 30, and then the risk comes down. And then I looked at the amount of the types of HPV amongst women with abnormal pap smear rather than women with cervical cancer. And from 2018, we were doing a co-testing. And yes, women with abnormal smear, a significant number in Jordan, they have HPV. And if you look at these genotypes, we have a mixture. And actually, more than 75% of women, they had more than one single type of HPV. So we have the 30s, we have the 50s, we have the 16, we have the 18, we have a mixture. So what do women know about this cervical cancer? So we did a small survey at the Jordan University Hospital where I used to work, and asking women, have you ever had any form of cervical screening? And only 27% had ever one cervical smear. And we know that's not protective. And when we asked them about how many of them actually had a cervical smear in the last 3 years, and only 7%. So that's really polling data. If you ask those women about what do they know about HPV, only 5% strongly agree that it has to do something with cervical cancer. 25% agreed, and the rest, they have no clue. If you look at the risk of smoking, smoking in Jordan is really increasing dramatically, especially amongst females smoking shisha. And again, if you look at their awareness of warning signs, looking at the Bloom's method, only 7% they are aware of early signs and symptoms of cervical cancer. So I think this is where we really need to put our money on awareness. And I like to tackle the problem from a different perspective. I'd like to look at the generation of Jordan. We all know about that, the divisions of generations. We have the baby boomers, the Gen X, which I belong to, Gen Y, and the Gen Z. And what really interests me is the Gen Z. We're planning for the future. So basically, every generation, they have their own specific behavioral changes, because I look at cervical cancer as a behavioral disease. So the baby boomers are the baby borns after the Second World War, Generation X, 70s, 60s, 70s, and the Generation Y, the millennials, 1980 to 1996, and the Gen Z, the youngsters. And if you look at the Gen Z, they have that knowledge about computer. If you look at the Gen Z along the world, if I show you a picture of a Gen Z, you wouldn't know that these are Jordanians or British or coming from. Maybe you can look at the color of the skin, but people are generally dressed the same. And 11 things you don't know about the Gen Z is that they are attached to technology. They have their mobile devices with them. So the music is their language, and probably the whole world is their familiar. And 11 things that you don't know, they have some sort of a boyfriend or a girlfriend. I'm not suggesting that this is our society, but I think that we have to be wary that these changes might. And the Gen Z are the ones who age between 8 and 23 years. So these women are about to get into their productive part of their life. They wanted to get married, they want to have children, and that's where they will be exposed. So these Gen Z, I would like to concentrate, because they are our future. They have their strong points like any other generation. The economists describe them as educated, which means we can outreach to them easily. We can target them easily by knowledge, and knowledge is power. Yes, they are less happy, the unhappiest generation ever, with a happiness score of 50%, but they are stressed and depressed. So again, back and again and again, do we really need to have a cervical screening program? I think we need time. We need to look into the future. We need to look into projections. We need to have more data. We need to have pilot studies along the nations. We need to have a look into that. I am aware that screening program has already started in United Arab Emirates, in Saudi Arabia. I was in Morocco a couple of years ago, and under Her Royal Highness, they are starting some sort of cervical screening program. So the whole world is preparing. And I know there have been 2 studies in Lebanon. One of them is still not yet published by the AUB, where they're suggesting that cervical screening is definitely cost effective. And another one, which was presented by Dr. Maher Sadiq, is not cost effective. So we're talking now, but we're not talking about the future. And if I wanted to talk about the management of cervical cancer, of course, the earlier is the better. The type of surgery we do for cervical cancer, it's not the best type of surgery. Ernest Wertheim started to do this type of surgery with a mortality and a morbidity rate was very high. Shortly after that, we had access to radiotherapy, and we are treating now advanced cervical cancer with radiotherapy. If you look at the outcome of surgery and radiotherapy, or sorry, the chemoradiotherapy, you will find comparable efficacy. So the survival with surgery and the chemoradiotherapy is almost equal. But the last thing you wanted to do is to do a surgery for someone, and then you discover that you have closed margins or positive lymph nodes, and then you give chemoradiotherapy, where the side effects would be tremendous. And that's why cervical cancer management should be done in tertiary center with people dealing with cervical cancer day in, day out to minimize the problems. And we know the chemoradiotherapy is the gold standard. It offers better survival in advanced stages. But again, it's not without risks. In a study published in 2013, they followed women for 30 years who had a radiotherapy. And those women, their survival was reduced because of a secondary cancer related to type of radiotherapy. So the idea of cervical screening is prevention of cervical cancer. If you have a screening program, if you have vaccination, you do not get that number of women with cervical cancer. And those women are detected. They are detected at an early stage that is amenable for surgery rather than leaving them for the gloomy future of the radiotherapy. And if I want to concentrate a little bit more on the surgical part, classically, we've been doing radical hysterectomy for stage 1A2, which is more than 5 millimeter. And it's a horrible type of surgery. We're putting everything in one bucket. But there is a significant morbidity. And that morbidity comes from the parametrectomy. And the parametrectomy and the lymphadenectomy, eventually you would have some sort of autonomic nerve dysfunction, urologic and rectal dysfunction, although we're trying to go around these side effects. And over the last 10 years, we've been asking the same question. Do we really need to do a radical hysterectomy for women stage 1A2 and more? And lots of studies suggesting that the risk of parametrial invasion is less if you have a very small tumor, if you don't have lymph nodes, if you don't have lymphovascular space invasion. Studies on and on showing how effective to do a conservative type of surgery, especially women who don't have children. And many people suggested to do a simple trachelectomy as opposed to radical trachelectomy for a microscopic type small lesions, or a cone biopsy, or a radical trachelectomy with or without lymphadenectomy, depending on the case. So each case should be studied differently. The simple trachelectomy is an easy procedure to do. It doesn't take much time. And people were looking into that. And that's why, because we needed a tool to triage patients, which one to do a conservative surgery, which one to do an extensive surgery, which cases we need to differ for chemoradiotherapy, we were badly in need for a revised staging. And in 2018, I was very glad to see that the cervical cancer, we were expecting this. I was presenting on cervical cancer in the presence of the Dini Carlo, the president of ESGO, and the vice president of IGCS. And I was telling them about the oldest textbook of medicine from Al-Zahrawi, and how he was telling us that small tumors can be removed by surgery, larger tumors should not be touched. And Dini Carlo quite agreed on that. And he said, this guy got it right from the first time, and we got it wrong. And he asked a copy for a book, which I sent to him. And yes, you cannot treat a small tumor, 5 millimeter, same like a one with a 4 centimeter. And hence the new changes in the staging came into place. And you can see now it's a little bit complicated, but yes, if you look at stage 1B, you see more than 5 millimeter, less than 2 centimeters. You look at more than 2 centimeters to 4 centimeters, and more than 4 centimeters. Each of them should be treated differently. And not only the stage, because previously a cervical cancer has been staged clinically. But with this new staging, we can use imaging as or pathology as part of our tools. Lymph nodes were not part of the old staging, but now they were incorporated. And you can say that the lymph nodes were enlarged by radiology and having the suffix R, or P, that means pathology, where a sentinel lymph node biopsy or a lymphadenectomy was done and the lymph nodes were positive. So I have big faith in this new classification and that we should be able to manage. But the data I looked from Globacon, that 60% mortality of cervical cancer in Jordan, that is really not acceptable. And you would expect this sort of mortality if you are diagnosing it late. Many of the patients I used to see in Jordan, they're coming at a very late stage that there isn't much you can do for them. And then the NCD and guidelines reflected the most recent staging. The other thing is we stopped looking at the lateral spread 7 millimeter or more. What matters is the depth of invasion. So we look whether it's less than 3 millimeter, 3 to 5 millimeters, or more than that. I'll skip on a little bit on the staging, and then I will go for different types of radicality. So we have different stages, the Peever-Rutledge, the Simmons, the Curley-Darja. The one in 2008, Curley-Morrow, they introduced a new theme of removing the parametria. They look at the ventral parametria, dorsal parametria, lateral parametria, and they have different sorts of radicality, which was further modified in 2017. And you can see now we can tackle and treat cervical cancer depending on age, depending on desire for fertility, depending on how big the tumor is. It with the inner part of the inner third of the stromal invasions or the outer third. So all these things we put together and then counsel the patient properly. The ESGO and European Society of Radiology and the European Society of Pathology, they had a great paper on the guidance of how to tackle these kind of tumors. The second part of my topic is I'm going to talk about the fertility sparing surgery, especially in our part of the world where women look at the uterus as a dear organ and as a sign of femininity, and they look at the uterus. You know, a woman without a uterus will look at herself as a distorted image. And most women, they delay their first child until after the age of 30. So especially in our region, it's extremely important to have a training in these kinds of procedure. The radical vaginal trachelectomy proposed by Daniel Darja in the 90s, which was a evolution of Schauter's kind of surgery, where from the vagina you identify the ureteric roof and then you do a radical removal of the cervix plus the parametria, and with the help of laparoscopy we can remove the lymph nodes. And the people started to do abdominal trachelectomy, and each procedure they have their pros and cons. The idea is to remove this segment of the cervix, and some people remove the uterine artery, some people don't, but most of them, they prefer to remove the uterine artery. With the anastomosis, the uterus should be able to survive, and we put a cerclage around the cervix, and the oncologic outcome in terms of recurrences and death has really been comparable and good, whether abdominal radical trachelectomy, laparoscopic radical trachelectomy, robotic radical trachelectomy. It's unestablished and it is safe, and people can do it. But it's not for everyone. If you have a tumor more than 2 centimeters, probably it's a bad idea. It's really for women who wishes fertility and women less than the age of 40, a small tumor, and no evidence of metastasis. And because of women who needed a proper radical hysterectomy, where the tumor is more than 2 centimeters, from 1951, Bayashi started a nerve-sparing radical hysterectomy, which is now widely practiced across the world. We try to serve the hypogastric nerve plexus, so you don't have the side effects of effect on vagina, effect on intercourse, sexual activity, and senseless areas. And you can see that the nerve-sparing radical hysterectomy confers a much better quality of life for women who had, as opposed to a standard radical hysterectomy. But again, sometimes you don't have a choice but to go and do a C2 type radical hysterectomy where you have to go and remove them. And the last part is I want to talk about minimal access surgery because we're really shocked, especially after the data is coming on and on from different studies. We looked at the comparative studies, RCTs, looking at the management of cervical cancer by abdominal radical hysterectomy or a endoscopic or laparoscopic radical hysterectomy. And the conclusion was there has been a lower rate of disease-free survival and overall survival in the laparoscopic arm. Still, we did not figure out why this is happening. It could be because of the CO2 circulation. It could be because we are opening the vault into the peritoneal cavity. But many hospitals are now going back. So it was really a setback to go to open surgery. Many centers advise that we should counsel women that you have a higher survival with an open, little bit lower survival. What do you want? And women wishes should be taken into consideration. The study was unequivocal that open surgery provides a better survival, a better disease-free survivals, and a better local regional recurrence. I am wary of time, so I will conclude by take-home messages. I think prevention remains the best strategy to tackle cervical cancer. And I think any suspicious lesion in the cervical cervix should be biopsied rather than smear. So smear is just screening and not managing suspicious lesion. Cervical cancer treatment should be centralized. It has to be in a tertiary center. We don't want people to start fiddling around and doing biopsies and doing different kinds of images. It has to be a multidisciplinary team meeting. It has to be a group decision rather than a one-person decision to improve morbidity and mortality. And if anything I would like you to take home from this message is really we need to concentrate on awareness. And this Congress is one of the best platform to spread awareness amongst healthcare providers and amongst patients. We need to outreach either through social media or through a different types of platform to Gen Z, because I believe that Gen Z health is our responsibility. They are our dear sisters and daughters that we need to look after. We need to keep them aware of what's ahead of them. And that's where I see there is an opportunity for a vaccine and there is an opportunity for a cervical screening. I don't think we need to reinvent the wheel and go for a classical conventional type of cervical screening with a conventional. I think the HPV testing is evolving day by day and the price is coming back. The study presented by Dr. Maher suggesting we can do it every 5 years. I spoke with Xavier Bosch, who's done extensive studies. He said, probably we can do it every 8 years, but still the data has not matured yet to make that suggestion. But again, it's about health economics. You need to balance the cost and the effectiveness of such program. With that, I conclude my talk. And we're still at the very beginning of battling cancers. And I hope that the coronavirus pandemic will reroute lots of money into the healthcare system, where we have a lot of money for studying and for promotions of and finding a cure for our cancers. And thank you very much.
Thank you so much, Dr. Mazen. That's really great presentation. I think now after all these, well-enriching presentations, I think we can have a session of discussions. I think Mazen, you are leading on this with as well Dr.
Yeah,
just check.
with the whole team. Yeah.
With the whole team.
Directed by you, Mazen, and myself as well, and Dr. Bassam Hijawi.
Yeah. Thank you, Ahmed. I'm aware that you might need to go for your surgeries, and probably I will start with you, Ahmed.
Yes.
Ahmed, do you think is it really worth it? to do some sort of a screening program? Do you think we need to reinvent the wheel and go for conventionals or HPV? What are your reviews, especially you root from this part of the world? What are your thoughts about what we've said earlier?
I think it's very interesting. I think what I was thinking while you're talking, all of you, I was thinking, I think there was some focus on the numbers. I know the numbers compared to other cancers are not high. However, the problem with cervical cancer, it targets younger women, targets women with kids, women who are fertile. So, like, I don't know if you all know the story about in the newspaper, maybe imagine when you were here about this celebrity, you know, Goody.
Hey, yeah, I was there.
Yeah, and it was all heartbreaking for the whole population that this happened. So one case was enough for a policy in the whole country. So that's one thing about cervical cancer. So I know numbers are less than ovarian. I know that numbers are less than other cancers. Breast is the highest number. Still in the UK, breast is the highest number. But I think still there is a need to use the opportunity of screening and vaccination. So which is first? I don't know. That's again with the lecture of Dr. Zghair about which we need to implement, which is more cost effective. That's lots of political and economical factors are played in here. But I think certainly there's no doubt screening is very important. I don't know if you all know that recently the UK moved to using HPV for screening. So we're not using the liquid-based anymore. You know, we were starting in my training time, Papa Nicola was the first, and then we moved to the liquid-based. And now we're using high-risk HPV only for screening. So the ones with negative HPV, they're back to the normal screening schedule. The one with positive HPV, these are the ones, then they come to the colposcopy. Now the colposcopy is normal, they can be discharged. If the colposcopy is abnormal, if there's any doubts, then up to the colposcopy to ask for the cytology to help with the diagnosis. So the pathways changed a lot in terms of screening, but certainly screening is very useful. It's the first line. The vaccination, when we first started, we said vaccination only if, to offer to the patient, but it wasn't part of the system. But then later on, by the years, when the economy and the economical policy allowed us to add it, it's been added. So I think if I want to plan, if I am the prime minister, let's imagine, I think vaccination will come second after screening. I think screening is more useful, and screening, a very robust screening system for everyone, not the opportunistic one, is the way forward. That's my opinion, but that's, at least we need to have one thing or both, but we cannot just ignore that we don't have anything and we just depend on opportunistic screening. I don't know what the rest.
I think I would like to hear from Dr. Maher about the projections of the future. I know we have an economic problem in Jordan. Not all patients have the privilege of being treated at the King Hussein Cancer Center. But what are your views about moving from conventional into HPV testing? Dr. Maher, is he with us?
Thank you. Yeah, I'm here. I'm using my phone now. Okay, thank you. Okay, well, let me first
everyone to just mute their mics.
Everybody should should mute, right? Okay, is it clearer now?
Yeah, it's clear.
All right. So first, let me comment on Dr. Ahmad's recommendation and approach to screening, which is HPV testing. There are actually many advantages for HPV, high-risk HPV testing alone, in contrast to liquid-based cytology or even conventional cytology. The advantages are, of course, you don't have to have a trained cytotechnologist or even cytopathologist. You just get rid of it. And this is really good for areas with highly prevalent cervical cancer, because testing is done by the machine at the end of the day, and you don't have to train pathologists or even cytotechnologists. So that's a very good way for areas where you don't have this expertise. That's the first point. The second point regarding the health economics and actually Dr. Bishtawi's point or question. Patients are not all patients have the access to King Hussein Cancer Center. This is the situation in Jordan. That's true. However, you can actually put a policy for the entire region. Our entire region is actually poor. We are poor countries. I mean, besides the Gulf countries who can afford to do many things, the rest of the area are really from Iran to Pakistan to Morocco, very poor countries. So we have to really put priorities in terms of what we need to achieve. So screening is the way to go. And opportunistic screening, which is happening right now, is good, but we need to improve on that. I think we have to, all patients, it's can very simply introduced. All pregnant women who go to their gynecologist or obstetrician for the first visit, they can get a pap smear at that time. As of course, they have to be older, not, in their early 20s. Of course, that's not, you could do a pap smear then, but doing an HPV test is not recommended below the age of 30, as you all know. So my answer, yes, we have to do screening. Patients cannot, we don't want to wait until you get the advanced cancer. As you can see from the figures presented that I quote from the WHO, the incidence in our area relatively is low. However, our mortality in the area is much higher than the mortality in other countries in the world where they have similar incidence, like Australia, New Zealand, and the US. They have similar incidences, but they have much, much lower, and that's because of the advanced treatment and management of patients, which we don't have in the entire region. I'm not talking about Jordan, we're talking about the entire region. Well, I hope I answered your question.
Yeah, thank you very much, Dr. Maher. My question is to Dr. Abir. Dr. Abir, you've run lots of campaigns for breast cancer, and you have a very prosperous, busy clinic. What are your views about our patient knowledge and attitude towards cervical screening or towards pap smears?
I want, first of all, to thank you all. And I had a small comment about the HPV, and I'm talking about now the coronavirus, like you commented on one of your slides. You know that coronavirus started in Wuhan city, and now it's all over the world. Okay, people are traveling all over. The world is now becoming like a big village. So our men are traveling out, our women are traveling out. So we are coating the infection. The HPV, we have it already. You said so. Dr. Mahed also said that we have HPV, and we have done a mild study here in Jordan, and we have the HPV infection. So we can't just close out of the world. We don't have corona in Jordan now. Okay, so we're comparing to the Italy, comparing to Spain, comparing to UK and USA. But we can't just be locked alone. Corona has to be eradicated from the whole world so we can open up. And the same happens with the HPV as well. You can't just lock yourself. We say that we don't have HPV. I'm not going to do a screening test. I'm not going to do vaccination. No, people are opening up. We're becoming a big village. So if you want to eradicate HPV and pap smear is a must. Vaccination is an option. You can't deny it for the people. Okay, and I have, since 2006, when we had the first vaccine here in Jordan, I vaccinated my daughter. She was 15 years old. So we're opening up. We can't be locked out from the world. HPV is there, cervical cancer is there. It's a killing disease. Why wouldn't I do a national program? We need really a computerized database for all the women that need to be screened here in Jordan. That should be done by the Ministry of Health. Then I have to do the smear every 3 years. I have to do the co-testing every 5 years. It will be cheaper than to treat the cervical cancer. So from my knowledge, للأسف, we had a lot of knowledge about coronary heart disease, we had a lot of knowledge about breast cancer, osteoporosis, but we don't have knowledge about cervical cancer in my patients coming to my clinic. Have you done it? No. Have you been proposed with doing a pap smear? No. Have you heard about it? No. You have done the study, Mazen, and you've seen that the knowledge is. So we have to spread the news. We have to have a campaign about cervical cancer, going along with the campaign of breast cancer, because it's doing a good job, the breast cancer campaign. And we need a database of all the women that needs to be tested, either by pap smear or co-testing or HPV alone, you know. Thank you.
Thank you very much, Abir. And that sums it all. I think if you ask healthcare providers, would you vaccinate your daughters? Most of them would agree. I would vaccinate my daughters, but it would be a better form if it's organized through a cost-effectiveness campaign.
Can I have comment, Dr. Maher?
Yeah, sure. Please go ahead.
Good morning, my colleagues. Actually, it's an interesting presentation from all of my colleagues. But you know, I am not gynecologist, I'm epidemiologist, and I want to give you my experience in the Ministry of Health. Usually, as a Dr. عبير عناب سامعين صوتي؟
Yes, doctor, go ahead.
Yani, as Dr. Abir Annab mentioned, usually the national screening programs usually led by Ministry of Health, and to activate any program at national level, you want first to convince the policymakers and the parliament people and the economic burden of the country. Sometimes it's affect these types of programs. And if you reflect the cancer registry data, all your presentation said, even you explain it by WHO estimation, but we have effective cancer registry in the country, and this reflects that cancer cervix not appears from the first 10 leading causes of morbidity in Jordan. So to convince decision makers, this is difficult for them. You need, for example, there's a lot of people, a lot of agencies, even UN agencies working on breast cancer. Why? Because it's the first, even among female or even at the level of all types of cancer. So we need a committee, and we can use our صحتي, our initiation to have a pressure on the Ministry of Health by a committee like your حضراتكم, بحيث ان احنا نعمل pressure on the Ministry of Health and explain for them the idea behind the importance of screening. Let me have an example. For example, now we have corona pandemic, and أنا عضو هلا في لجنة الأوبئة الوطنية. the Ministry of Health working 80% until now on corona still. So all our activities is stopped. I am retired, but I am working now with the Ministry of Health as consultant for family planning. Even we have included all behavior issue like Dr. Mazen said, but for every types of non-communicable diseases, including cancer, but still we want a time to convince the minister, to convince the committees at the level of national level or at the level of Minister of Health. This is what I want to comment.
Thank you very much, Dr. Bassam. And I really second your suggestion. I think we need to convince the policymakers about the projections of the future. And I think, more than 50% of women in Jordan, they are insured, either by the Ministry of Public Health or by the military services. So I think looking at cervical cancer is not looking at breast cancer. Breast cancer, you try to identify the disease at early stage. But with cervical cancer screening, you are preventing the cancer from occurring. And I think that's where we can develop our new guidelines. I would like to ask Dr. Ihab. Dr. Ihab, are you still with us?
Yes, please.
Yeah, because you work in the military hospital where all your patients are insured, so they don't pay anything for their services.
Yes.
What's the take of cervical screening? Do you think women are doing their cervical screening properly? Do you think healthcare providers on the general practitioner side are not doing enough of smears? What are your views about that?
Okay, Dr. Mazen. I think this is a big issue. And for my opinion, the one who should be blamed for the poor screening is the health work providers. If we can't convince OBS and gynae doctors to do pap smears or to advise their patient to do a regular pap smear, how we can convince like the ministry to provide the vaccines, especially with the hospitals with fully insured patients. So I'm sure in Ministry of Health, even the military hospitals, university hospitals, just the minority of their patients have a regular or even offered screening methods to be collected. This is well known. So if we want to start from a point, we should start from the health work providers, and we need like brochures or something for the patient to ask about the screening methods. We can't leave the patient like this. They are very young and they worth something to be done. So this is my opinion, and I think we need more work on the health work providers, especially with the residents. We used to examine like a board doctors for the specialty, and you'll be amazed that some of them, they never collect a pap smear. They are going to be a specialist and they never collect a pap smear for their patients. So I think we need to go from there.
Yeah. Dr. Ahmed, are you with us? Ahmed Sayasna?
I can hear you.
Yeah. Dr. Ahmed, you had a vast experience in screening, treating cervical cancer, where we think HPV is a stigma. And if they are going to be HPV positive, that will have so.
It's a long consultation process. We had many occasions where the lady will, either accuse her partner of being unfaithful or either having, issues that, her partner thinks that she is the one who's unfaithful. So we had cases like this. Now, the thing about it is about educating, and part of the consultation, you just explain actually, HPV is very common. It's a commensal virus which lives with us. About 90%, more than 90% of couples in some areas who are sexually active, they will have HPV. It is not about the HPV. It is about what HPV can cause. So when you start, and it's not considered, by the way, it's not considered an STD, although it is a sexually transmitted disease or sexually transmitted, but in the STD, HPV is not being an STD. It's not treated an STD. It's not, there's no tracking of partners. It doesn't follow the same guidelines of the EMPHNET. So the EMPHNET as well play a very essential role in educating the team and our couple when there is an HPV. So it's all about counseling, all about explaining why we're doing it. It's part of the colposcopy session. So all this information the patient will gain normally comes from the colposcopist, who will reassure her, tell her what the role of this clinic. It's a preventative medicine clinic. We are here to prevent cervical cancer. STD, you don't have an STD. This is an HPV as a mechanism or as an etiology of your disease, but we're not interested in that. It's a self-limiting virus. It disappears on its own, but we want to make sure that it hasn't caused any damage or any problem in the cervical lining, which can become cancerous over the many years. When you start explaining that to the patient, they calm down and they understand actually, okay, I'm not stigmatized anymore. It's very common. It's something happens to almost 90% of the sexually active people. So it's a different talk. So it's about how to talk to the woman. I think it's very important.
Thank you very much, Ahmed. Yes, yeah, I totally agree with you. And I think the younger patients coming to my clinic, you know, I started to see unmarried women coming with a smear because they are wary about the possibility of HPV. The knowledge is coming up. For the sake of time, I will need to conclude the session. I'd like to thank the organizing committee. I'd like to thank our distinguished speakers and our moderator, Dr. Ahmed. I think the main message from this session is really we need to have more data from this part of the world. And we need to concentrate probably more on the knowledge and attitude of our patients and healthcare providers, and leave the vaccination and the screening till a later stage. Once we have a solid ground with our patients, we are going to have a pressure groups, patient-centered pressure groups, whom they might be able to convince our policymakers to go. Thank you all very much. And I think it's the time to go for the next session. Thank you all.
Thank you.
Dr. Suha?
Thank you.
Thank you.
Thank you.
Are we ready for the second part?
Just a second. I just want to, for all the people who are watching us, I will just, if you allow me, I will just talk in Arabic. للناس اللي معنا موجودين عم بيحضروا المحاضرات. معلش لو سمحتوا إنه كان في الصبح إشي تقني. كان في ايميل انبعث لكم بلينك غلط من الزوم، هذا شيء اوتوميتد من الجوجل، ما قلنا احنا دخل فيه. فطبعا هذا اللينك اللي راح يضل المؤتمر لليوم ولبكره ولكل السيشنز. فيا ريت انه الناس تشيكوا، تبعتوا لهم هذا اللينك عشان يكون صح. وانا بعتذر عن جد عن هذا الغلط، يعني كان يا ريت انه احنا تجنبناه، بس بعتقد انه ان شاء الله ملحوقه. وبعتذر للسبيكرز لانه في كان 30 او 35 واحد ما قدر يشوف اول سبيكرز لانهم كانوا داخلين على روم غلط. again يعني هذه يمكن أول تجربة بالفيرتشوال كونفرنسينج، متوقع يصير هيك إشي. إحنا بنعتذر، بس الجود ثينج about it إنه كل السيشنز سجلت على اليوتيوب، رح تكون موجودة، والأكسس موجود لإلها وفري. وبدي أشكر السبيكرز من كل قلبي لأنه كان عن جد مستوى كتير عالي من النقاش. I would like to thank all speakers for their contribution because it was really outstanding and the discussion is so important. We're hoping that this will lead to guidelines and something on the, you know, real to be beneficial to our patients. With this note, we will just start within like a couple of minutes the next session. We have the moderators ready.
Yes, we are. Yes.
I will shift to Dr. Marwan Al-Zaghal and Dr. Bassam Hijawi will be the moderators for the next session.
نعم, we are ready.
Dr. Marwan, do you like to present yourself? Okay, Dr. Marwan and Dr. Bassam, you take it.
Good morning, everybody. Dr. Marwan is ready with me?
Yes, I am ready.
Yeah.
I am ready.
Let us start our second session that under the title of non-communicable diseases and maternal mortality. And we have four presenters, Dr. Saifuddin Saleh, Dr. Maher Maaita, Dr. Maisa Khadr, Dr. Hani Kafawin. And I want to start with Dr. Marwan to introduce Dr. Saifuddin Saleh. Please, Dr. Marwan.
Yes, thank you, Dr. Bassam. We start the second session. First presentation will be maternal mortality and NCDs. Dr. Saif Saleh.
We are ready. Dr. Saif. Dr. Saif Saleh is a medical epidemiologist. He was head of NCD section and head of surveillance section. He is a trainer and lecturer in Arab Board of Community Medicine. Dr. Saifuddin is having an international experience at WHO, STB, WHO, medical epidemiologist in Sudan, Pakistan, and in Jordan. Dr. Saifuddin is working now at Eastern Mediterranean Public Health Network as EMPHNET as a medical epidemiologist. His presentation, as I said before, maternal mortality and NCDs. Time is yours, Dr. Saif. 20 minutes only.
من هون بغير.
دكتور سيف الدين. Just a minute because we have technical problems.
بسم الله الرحمن الرحيم. Thank you, Dr. Marwan. Thank you for صحة وطن initiative. I will talk about, and thank you for GHD EMPHNET for hosting our activity. I will talk about NCD, non-communicable disease, and maternal mortality. Actually, in the last century, NCDs start to appear early in developed countries and late in developing countries with relative control of communicable disease, mainly. محمد مش لازم يعمل تشينج اللي ما بده يمشي مش هون thank you. Non-communicable disease, they are diseases that have prolonged course. It's not resolved or cured spontaneously, and there is usually not complete cure, and it is multi-cause or multifactorial causes. It is not like communicable disease. When compared to communicable disease, as when we speak about TB, we said tubercle bacilli was the agent, the causative agent. When we speak about non-communicable disease, if we said what is the causes of cardiovascular disease, no one can say only one cause. We said there is a risk factors. The risk factors are more than one usually for any disease. These are the risk factors. As we see in this shape, it is multifactorial. When we take smoking affects cancer, cardiovascular disease, and respiratory disease, and others. If we take about alcohol abuse, it affect many organs. And the lifestyle, the same. When we divided the risk factors for modifiable and non-modifiable risk factor. Non-modifiable risk factors, that risk factors we can do nothing for it, like age, sex, or genes or genetics. We couldn't stop the age. We have to accept this risk factor. The behavioral risk factor or modifiable, tobacco, diet, alcohol consumption, physical inactivity, and stress. Actually, tobacco now, it is a global problem all over the world. It's more in developing countries, and particularly in our country, in Jordan. It is a real problem in Jordan, as in the last reports internationally, 80% of Jordanian men were smokers and 17% of the women. and the burden of the economic burden of the smoking, tobacco smoking in Jordan is about $2.3 billion per year. This includes not by buying cigarette, it includes direct and indirect cost. Within socio-economic, cultural factors and environment as air pollution. في عندنا intermediate risk factors, hypertension, blood lipids, obesity, overweight, and diabetes. Also, it is related to behavioral risk factors, which is a healthy lifestyle. Usually we speak about eating. All of us, we eat more than we need. Physical inactivity, now our behavioral was changed. Most of people use their cars even if they want to visit their neighbors. They use their cars. They will not go buy on foot for physical activity. Mortality due to NCD, it's around, globally, it's around 41 million people worldwide died of NCD in 2016. It represents around 70% of all deaths. This is globally, and at the same time, it is in Jordan, it goes with it. Around 18 million deaths due to cardiovascular disease, 9 million due to cancer, 3 million deaths, and 1.6 million due to diabetes and its complication, and others due to injuries. Characteristics of non-communicable disease, as we said, it's uncertain etiology. We couldn't say one cause that could lead to a communicable disease, either cardiovascular or if it's cancer or diabetes, also it is multifactorial risk factor. Long latency period. And this is a problem in controlling of these diseases. When we talk about the risk factors, usually it takes a long time to cause the disease. When we spoke about smoking, we know that smoking is not after you smoke 20 cigarettes, you will get a CA lung or cardiovascular disease. It's a long time. This is communicable disease. This is population all over the world. They comply with control measures regarding communicable disease because they see the effect immediately. I give an example of COVID-19. Now, people all over the world, they use the mask, they use the social distance because immediately they saw people in hospitals, people dies. But when you speak about physical activity or smoking, controlled smoking, it needs a long time for that. Then indefinite onset. When we diagnose a case of hypertension or diabetes, we didn't know exactly when it begins. Prolonged course of illness, usually non-communicable disease, stay with the population forever. Yani people can live with hypertension or diabetes 20, 30, 40 years. It is non-contagious origin. Usually it is not transmitted from person to person. As we said, there are risk factors. It leads to functional impairment or disability, incurability. It is not curable radically. And it has a very big economic burden for the community and the countries because the population, the diseased persons live for a long time and they need treatment for a long time. This is as a direct cause. But there is an indirect cause. It is the degrees of productivity of those patients. When they become ill or hospitalized, they will leave their work. This will affect the productivity of them. This photo represents the change of behavioral lifestyle. If we see a man driving a car and he was walking for his outside to make the dog walk, to do physical activity while he is in his car. He's driving a car and the dog is walking beside him. It is there. You can see it. The same as the same that is for lifestyle in our eating habits and smoking, unfortunately. Now we'll go to maternal mortality. Before we start maternal mortality, I have a comment. Usually pregnancy and delivery, it is a separation event for the families. When a lady becomes pregnant, her family and the husband family are waiting for 9 months to get a new visitor, a new member in the family, and they are preparing for celebration. It's injustice that the lady will discharge from the hospital as a dead body. So by definition, maternal mortality is defined by WHO as the death of a woman while pregnant or within 42 days of termination of pregnancy, irrespective of the duration and site of pregnancy, from any cause related or aggravated by the pregnancy or its management, but not from accidental or incidental. Yani, if a mother was died due an RTA, it's not considered as a maternal death, even if she was pregnant. The same as if she was killed for any cause. Either even if she was suicide, also it's not considered as a maternal death. The causes and contributing factors of maternal death, usually they are medical causes and contributing factors. Medical causes, we have direct and indirect cause. Contributing factors, we have medical and non-medical causes. Causes and of maternal mortality. Globally, around 80% of maternal death are due to obstetric complications, mainly hemorrhage, sepsis, unsafe abortion, preeclampsia or eclampsia, and prolonged or obstructed labor. Complication of unsafe abortion account for 13% of maternal mortality deaths worldwide. Almost all cases, or most of them, are preventable. And this is very important. That we can prevent most or all cases of maternal mortality if we take care of the mothers during antenatal care visits or during labor or after in puerperium period. An estimated 74% of maternal death could be avoided if women had access to the intervention of preventing pregnancy and birth complications and emergency obstetrics. These are medical factors and non-medical factors for the causes we said about. The maternal mortality ratio, usually it is calculated by dividing number of maternal mortality and a number of live births per 100,000 live births. In 2017, maternal mortality ratio were estimated as 140 maternal deaths per 100,000 live births globally. Around 80% of all maternal deaths occurred only in 13 countries in 2017. Look, this means there is a cluster of maternal mortality in certain countries. SDGs globally, number 3.1, the target for maternal death is to be less than 70 per 100,000 live births by 2030. This does not mean that if we reach this less than 70 now, to take a rest and not to work. Even those countries or communities who reach this target, they have still to work to prevent this maternal mortality and decrease it to be as much as it can. These are percentages of medical causes of maternal death in the world. hemorrhage represent 24, around 1/4 of cases. Sepsis 15%, unsafe abortion 13%, eclampsia 12%, obstructed labor 8%, other direct 8%, indirect 20%. We have three delay model when dealing with maternal mortality. First delay model, it is delay in seeking care, which is failure to recognize danger signs or lack of money to pay for medical services or transport, or fear of ill treatment at health facility and unwilling of the mother or the family to seek care because of cultural limitations. And this means that either the family, they couldn't recognize the danger signs, and there are symptoms and signs for the pregnant woman, and she and her family, she didn't recognize that she was in a danger and she had to seek for medical care. Or sometimes they know that they know these signs, but they have financial problem, they didn't enough money to pay for the services if it is payable. Or sometimes it is cultural issue. Cultural issue, sometimes either her mother or her mother-in-law or her neighbors or any of old relatives, they said, no, don't be spoiled. This is, we have born 10 times before. We have these signs. There's no need for doctors. Or sometimes the family she need a female doctor, gynecologist to deal with her. She don't need a male, and that's not available, the female doctors. Second delay, it is delay in reaching care. Distance from one's home to care facility or provider, lack of roads or poor conditions of roads, and lack of emergency transportation. In Jordan, we don't have this problem. We have the Jordan mortality surveillance system, and during 2018, we have 0 cases in delay to a number in second delay. Delay 3, number 3 is delay in receiving care, lack of healthcare personnel, and insensitivity of healthcare providers and shortage of supplies, as sometimes it is due to degrees of blood or some instruments, especially in remote areas. Maternal mortality has declined, but its progress is uneven across region. A total of around 300,000 women were died, lost their lives during and following pregnancy and childbirth in 2017, with around 85% occurred in Sub-Saharan and Africa area and Southeast Asia. These are the 30 countries that we said about. Around 80% of cases occur there. The global maternal mortality ratio was estimated at 2011 to be representing 38% reduction since 2000. Yani from 2000 to 2011, the maternal mortality ratio was decreased by 38%, which is good improvement, but still in some communities, it is still very high. It's thousands per 100,000 live birth. On average, global maternal mortality declined by around 3% every year between 2000 and 2017. Where do maternal deaths occur? The higher number of maternal deaths in some areas of the world reflects inequalities in access to quality health services, and highest the gap between rich and poor. The maternal mortality ratio in low-income countries, it is around 462 per 100,000 live births, compared to 11 in high-income countries. The gap is very big. This means there is inequity and injustice in gaps between rich and poor countries. Why do women die? Women die as a result of complication during and following pregnancy and childbirth usually. Most of these complications develop during pregnancy and most are preventable or treatable. If we have antenatal care visits and properly in number of visits and the quality of care during these visits, both maternal and childhood will be improved. Even neonatal mortality will be decreased, not only maternal mortality. If we improve the quality of antenatal care during pregnancy.
Dr. Saif, you have 2 minutes more.
That account for nearly around 75% of all maternal deaths are severe bleeding, either postpartum, antepartum, or intrapartum, infections, usually after childbirth, high blood pressure during pregnancy, preeclampsia and eclampsia, complications from delivery or unsafe abortion. Why do women not get? Poor women in remote areas are the least likely to receive adequate health care. Usually, good services, especially in developing countries, in the third world, concentrated in the capitals of the country, in the city, or in the capital of the governorates.
Dr. Saif, you have 2 minutes more.
The main factors that prevent women from receiving, seeking, or during care are poverty, distance from facility, lack of information, inadequate and poor quality services, and cultural beliefs and practices. And we have commented on these factors before. Prevention of maternal mortality, usually we said that most of cases are preventable or all. Early detection of disease and improve quality of antenatal care visits and services. It will highly affect the cases and delivery under either in hospital or under health professionals, because in sub-Saharan Africa, where roughly around 66% of women maternal death occur, only 60% of births were under skilled health personnel till now. Yes. So let's go to the data. This shows distribution of maternal mortality by regions of WHO. We see Africa is the highest during 2005, 10, and 15. Our region, EMR, it is in between. It is like Southeast Asia and the world in general. Europe is the least, which means the best. Now we'll take EMRO countries. In EMRO countries, we have Saudi Arabia, Egypt, Jordan, and we see the Iraq, Pakistan, and Morocco have the highest. Also, we have in Afghanistan and Somalia, it's more than 1,000. That are two extremes. Kuwait and United Arab Emirates is the lowest. In 2017, we compare in the countries, we see Jordan in green. It is estimated, this is estimated by WHO, these numbers. It is around 46. And still Kuwait and Emirat, Oman, KSA is the best. These are with Europe, developed countries. After that, in Jordan, we have the Jordan Mortality Surveillance and Response System. It started in 2018, and the first report was declared in the last year, 2019 for 2018. I shall just put some.
1 minute, please.
Yes. These are the age group of the maternal mortality rate in 2018 was 29.9% birth, 100,000 live birth, which means that it is around 50% decrease than estimated by WHO in 2015. The most age group, it is increased by age group. The most rate or ratio in age group 40 to 49. Causes, around 90% of maternal death causes was due to non-communicable disease, because it's not only preeclampsia and eclampsia and cardiovascular disease. We consider pulmonary embolism is a non-communicable disease, and the complication of anesthesia, and also it is non-communicable disease, as well as the blood transfusion complication. These are distributed by place of residence and place of death. We see Amman, it is much when compared as place of death, but when you see place of residence is highly decreased, because many complicated cases was transferred from governorates to Amman for more best services. These are NCDs, and these are the delays. We said at secondary we don't have any case, and thank you.
Thank you, Dr. Saif, for your nice presentation. Dr. Bassam, we are ready to present Dr. Maher.
Yes, thank you, Dr. Marwan. Thank you, Dr. Saif, for your nice presentation. Is Dr. Maher Maaita available around?
Yes, I am available.
Good morning, Dr. Maher. Good morning.
Yes, I'm available, sir.
Our second presenter is Dr. Maher Maaita. The title of his presentation is Maternal Mortality in Jordan. And I think everybody knows Dr. Maher Maaita. He is a consultant of obstetrician and gynecologist.
Can I just ask the speaker, previous speaker, to remove his slides, please, because I cannot get my slides on.
Still, you need
yes.
Anybody to help, please. It's okay now. Still.
You can start. We've removed the stop sharing slides.
Yeah, I'm done. I'm okay now.
It's okay. Good morning, Dr. Maher.
Good morning, sir.
You know that Dr. Maher is a consultant obstetric and gynecology. He's the head of department subspecialist in C2 maternal medicine in King Hussein Medical Center, Amman, Jordan. And he's a clinical and associate professor for Faculty of Medicine in Jordan University. And I know that Dr. Maher, he is a member of the National Committee responsible for decision maker of maternal mortalities in Jordan. You're welcome, Dr. Maher. Please.
Thank you, sir, and thank you for the invitation. Thank you, Dr. Suha. Maternal mortality is a very important subject, as we heard from Dr. Saif. What I'm going to do with my presentation, I think he covered the subject globally. I'm going to concentrate on Jordan. I think for any person who works in the field of obstetrics and gynecology, maternal mortality is a very important subject. It's very sad for us as obstetricians when we lose ladies who came to have babies. So maternal mortality is any loss during pregnancy, complications of pregnancy, or within 42 days after delivery. If we look at the studies that have been done in Jordan back in the 90s, we can see that what has been reported as maternal mortality in Jordan is in the range of 41.4 per 100,000 live births. And what was reported at the time that hypertensive disorders were the leading cause for direct maternal mortality. Cardiac diseases were the leading cause of indirect maternal mortality. So that back in the 80s. So we had an idea in the 90s, that the mortality rate in Jordan is in the range of 40 plus minus per 100,000 deliveries. However, later on, 2006, 2007, we had more studies which looked at hospital deaths and things like that, and they came up with a figure of 19, which was probably below what most obstetricians in Jordan would expect. Although it's not believed it was a true reflection of the situation due to the problems in identifying and reporting deaths, observers in Jordan maternity professionals believe that the range is between 50 and 60. And we were, during our work, we were probably looking at this range when it comes to maternal mortality in Jordan. Now, more statistics, we had some, UNICEF gave an MMR Jordan of 63, and a hospital study in 2006 looking to 2012 reported a range of 50. So we were really, we need a definite figures, we need good studies, and we need an audit of all the maternal deaths in Jordan, and we need figures which is recognized by the WHO and all our international partners. And this is where the project started 2-3 years ago with the support of USAID. And as we said, we had, okay. So this is where the GMMMSR started, Jordan Mortality Surveillance and System Response started. This is a project sponsored by USAID, and I'm pleased that I'm part of the project, and I'm grateful to all my colleagues who did a great job to make this project successful. And I think we are very proud in Jordan to work in this area, maternal mortality in Jordan, and now we have figures confirmed and probably recognized by international bodies all over the world. So I can go through the journey with you, and the aim was to quantify the maternal mortality ratio for Jordan. Active surveillance assigns a main cause of death for all these maternal deaths and define contributing factors to the death and a national system, which is important. So we had all the people from the Ministry of Health, we have the military, hospitals, representatives, the governments, the universities, the private sectors, working together to achieve this excellent project. Now, Jordan commitments to implementing this system, obviously the Ministry of Health, the host is the Ministry of Health, non-communicable disease directorate, and we are grateful as well that we had, it's by law, all maternal deaths have to be reported within 24 hours of death, and that's excellent, and the law passed back in 2015. So we're covered even by law and approved policies and procedures, and this is all very important, and this helped all the people who are involved in this project to make it a very successful project. So capacity to implement this project, technical competence built for all levels of implementation, and that's very important. And you can see it's a lot of hard work. We started with the National Advisory Group of 11 people. Dr. Bassam with us, Directorate Advisory Group as well, 91 focal points in every single hospital and forensic medicine department, 228, non-communicable disease directorate 3, and Minister of Health Electric Transformation and Information Technology Directorate 6, a total of 339 people who did a great job in bringing this report to light. Now, training was very important part of our work, and training of trainers as well, conducted for 34 members. And as you can see from the slides, different things and different operations, all working together to get this national project to light. Infrastructure as well, desktops, servers, laptops, tablets, and I don't want to keep thanking all the people who are involved, but I think everybody who was involved in this project did a great job. Tools and forms developed as well, and as you can see, Jordan Maternal Mortality Surveillance and Response System. And I believe that in the Arab world, I think we are second after Egypt, that we have an official maternal mortality report. And then we had the guidelines for implementing and develop these guidelines and the surveillance. So reporting period, this is very important. The result in this presentation covers the reporting period from January the 1st to December 31st back in 2018. And Jordan maternal mortality ratio was calculated for 2018. And during this reporting period, 1,247 deaths among women of reproductive age were notified through the GMMSR information system. And when we excluded all non-pregnant or non-related to pregnancy, we had a total of 60 unfortunate, 62 deaths were identified as maternal deaths. A total number of 207,917 live births in all of Jordan occurred during this same period that we are talking about. And that made a maternal mortality rate of Jordan to 29.8 per 100,000 live births. So this is now the official figure for maternal mortality in Jordan, and all our colleagues in this field should be proud that we reached to a definite figure. I know every life is sad, losing lives, but at least now we have the statistics to tell everybody that, unfortunately, back in 2018, the maternal mortality was 29.8. And if you look at this figure and comparing it to the previous speaker, worldwide, so we're not doing badly. Obviously, there are areas of improvement, but I think this is a starting point for the future. And it's very important that this figure is recognized worldwide when it comes to Jordan now. And we gonna probably not talk much about the previous figures. Now, maternal deaths by demographic characteristics of, let's say, we're gonna cover maternal age group, nationality, education level, employment, and place of residence. This is now, I'm just gonna take you quickly through the results of the report, briefly as well. Some of the slides were covered previously, but now if you look now, as you get older as a woman, then the maternal mortality will go up. So if you look, most of our deaths, unfortunately, were in the age group between 40 and 49, less between 35 and 39. So the message from this is maybe having baby earlier on is safer. Now, maternal deaths by nationality, if you look, obviously, because we are in Jordan, most of our maternal deaths were Jordanians. However, 9.7 of our maternal deaths were Syrian, unfortunately. We had few Palestinians as well, and unfortunately, we had one Pakistani lady who died while she delivered a baby in Jordan. Now, maternal deaths by education level, the majority of our maternal deaths had secondary education. 29.8 had higher than secondary, 22 almost had basic education, and 5.3 illiterate, which is a reflection of the Jordanian society when it comes to reproductive age. Now, maternal death by employment, you can see here that most of our ladies were unemployed or housewives in a way, i.e. they are not working. 10% of the ladies, unfortunately, who died were working or employed. Maternal deaths by place of residence, you saw the slide earlier. The majority of the deaths, unfortunately, were in Amman, and that's the capital, and that is expected because all the big teaching hospitals and referral hospitals are in Amman. And you had scattered maternal deaths in all cities in Jordan. Something that came up in Tafila, that we had no maternal deaths, but probably because they were transferred early on to Amman, or yes, to Amman. Okay. Maternal deaths by clinical characteristics, parity, timing of death, antenatal care, and mode of delivery. These are very important areas. And if you look at this, the majority of our ladies were multiparous, i.e. they had kids before, and that made it very sad, because if you lose a woman who had 5 kids, then obviously the impact on the family is huge. We had few nulliparous, but the majority of our ladies that we lost, unfortunately, were multiparous. Maternal deaths by timing of death, obviously the riskiest area for losing a pregnant lady is postpartum. So that's the area that we need to concentrate on. Almost 80% of our ladies were in the postpartum area. And the message should be clear to all the obstetricians in Jordan: look after ladies carefully after delivery. We had some ladies during pregnancy as well, and post miscarriages, which is similar to what is being reported globally. Now, so as we said, the majority in the postpartum period, and that's why it's important to keep a lady who had a baby or whatever, I think 24 to 48 hours after delivery. Now, maternal deaths by antenatal care visits. This came up because globally, if your antenatal care is good, then it will reflect on your maternal mortality. And maternal mortality is important because it's a reflection of your health system in the country you're working or practicing. It's like, so maternal mortality figures across the world gives you an indication how the country is doing when it comes to health system. And that's why we have high maternal mortality in poor areas, or areas where they have wars, for example. Like in Afghanistan, they had one of the highest maternal mortality rates. And we heard from previous speaker, the variations between maternal mortality between countries, between continents, and most unfortunately, maternal deaths worldwide is in areas which are poor, basically. And if you look even at the statistics in the United States of America, it's the richest country in the world, you will find variations between states, where in California, for example, the rate is quite low. Globally in the States, it's around 27, 28. So variations even in a very rich country like the United States of America. Now, antenatal visits, obviously, unfortunately, most of our ladies had regular visits, 4 visits and above. How effective were these visits? We have no evidence of, but obviously most of our ladies had regular antenatal visits. Now, maternal deaths by mood of delivery, and this is surprising to us as a committee, is that most of the deaths were related to cesarean section. And this is very important, and it has a very strong message to our obstetrician colleagues that don't take a cesarean section lightly, because it is associated with maternal deaths. And now we're working in a project, again, sponsored by USAID, to look at cesarean sections in Jordan and look at ways of reducing the rate of cesarean section. And that's a very important area related to what we're talking about when it comes to maternal mortality. Obviously, some ladies died after a vaginal delivery and died after miscarriages, and some deaths were not related to the delivery per se. Now, maternal deaths by causes of death. This is the most important slide of my presentation. And the message is that bleeding or hemorrhage is still, unfortunately, the leading cause of maternal deaths in Jordan. And this is an area that we should really concentrate on, because you have to have a referral system, you have to have blood banks, you have to have blood products, whatever. This is an area that we can improve. 30% of our ladies, unfortunately, back in 2018, died from obstetric hemorrhages. We have the other list of pulmonary embolism, amniotic fluid embolism, preeclampsia, sepsis, which is consistent with the reported figures nationally. We had respiratory system, circulatory system related diseases. Unfortunately, we lost few ladies with neoplasm as well during pregnancy, blood transfusion complications, and few ladies complications of anesthesia. So you can see an overall picture of causes of maternal deaths, but the most important thing, I think, and the message should be loud and clear, that obstetric hemorrhage is the leading cause of maternal mortality in Jordan, and we should do something about that. Now, maternal deaths by level of delay. Again, this is important, back to the question in what percentage of them were preventable or delay in the receiving treatment. And you can see there almost 47% had delay in receiving care, and no delay in a large percentage, but we had delay in seeking care, and we have delay in seeking and receiving care, and delay in reaching care as well. And that's an area for improvement, I think. And we got the message from the previous speaker about globally that 60 to 70% of maternal deaths are preventable. So if we can work to reduce this rate from say 30 to 20 in the next few years, I think that would be a great achievement. Now, it's important now, we have the figures, what are we going to do about those figures? How can we improve those figures and how can we improve things? So obviously it's very important to adopt strategies for the prevention and the management of obstetric hemorrhage. This has to be an overall in the kingdom, committees, blood banks, referral system, early to tertiary hospitals, identifying people with risk factors, competency when it comes to junior doctors, system, junior doctors reporting to senior doctors, acting quickly and swiftly, because if you delay your management when it comes to bleeding, i.e. you delay the surgical option of say hysterectomy, or then you're losing a window and then the woman will go into DIC and then complications, and then the damage is irreversible. That's a very important area because we're talking about 30% of maternal deaths. Adopt strategies to reduce causes of venous thromboembolism, and I would add to that preeclampsia and all the medical disorders, and sepsis in particular, because sepsis is quite aggressive. And we've seen ladies, we lost ladies with H1N1. Unfortunately, with Corona, we're okay, but we know that we lost lots of pregnant women with H1N1 previously. And sepsis is a very important area that we have to have red flags everywhere in hospitals, act quickly, start antibiotics, start IV fluids, take cultures, blah, 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 the whole list. So we have to have guidelines to manage all these causes of maternal deaths, have them, apply them in all big maternities and big hospitals and even smaller hospitals. So we have to adopt strategies to enhance the quality of antenatal care services, because antenatal care is the primary place where a pregnant woman will go and see somebody. So we have to improve that because it's a reflection of our health system in Jordan. And obviously the big project again that we have touched on, that we are working on, is to reduce primary cesarean section deliveries. Primary cesarean section delivery is very important, and that's a project that we're looking at. And increase the uptake of quality family planning methods as well. So these are the kind of recommendations that we came up with at the end of the project. And we saw that if we implement all these things, hopefully in next year we'll reduce our maternal mortality, and the year after, and the year so. And our target should be to reach a maternal mortality maybe of 10 to 15, like Europe, in the next 5 to 10 years. And I think that if we achieve that, then that's a great achievement. I believe strongly that no woman should die whilst bringing life into the world. And we as healthcare providers and obstetricians and gynecologists in particular should work hard to reduce maternal mortality. And I'm very proud to be part of this project. And I'm very grateful to USAID, Minister of Health, all my colleagues in the National Committee, for their support and for allowing me to share those results with you. And I conclude by saying thank you very much for listening to my talk.
Thank you, Dr. Maher, for this exciting and comprehensive presentation. I saw Dr. Hani Kafawin is ready. Dr. Marwan, can you introduce Dr. Hani?
I hear you, yes. Thank you, Dr. Bassam. So we will move now to Dr. Hani Kafawin because Dr. Maisa is not ready yet. Dr. Hani Kafawin is a general and oncoplastic breast surgeon at Royal Medical Services in Jordan. He is the head of General Surgery Department at Queen Alia Military Hospital. Dr. Kafawin is an epidemiologist examiner and associate in National University's Medical School. Dr. Kafawin, you are ready? Time is yours, please.
صباح الخير جميعا يعطيكم العافية. Today we're going to talk about breast cancer surgery management in pregnant ladies. Okay. Breast cancer is the second most common cancer in pregnant ladies after cervical cancer. Diagnosis and treatment of breast cancer in pregnancy faced by many difficulties. As we know, we are talking about two lives. We are talking about the lady herself and the fetus. So there's a lot of dilemma around this situation, so we have all to take care of it. What about the definition? Breast cancer in pregnancy defined as breast cancer diagnosed during pregnancy. Because of that, they took the name of pregnancy, and also not to forget, during lactation or within 12 months of postpartum. So it is the cancer, breast cancer that occurred during pregnancy, lactation, and within the first year after delivery. The incidence of breast cancer in pregnancy, it's estimated to be 1 in every 3,000 pregnancies. 10% of breast cancer are diagnosed before the age of 40. So we are talking about young age group. Average age of diagnosis about 32 to 38 years of age. The median gestational age at diagnosis is about 17 to 25 weeks. In general, there are a lot of physiological changes that occur in the breasts during pregnancy with the staging of pregnancy, starting from first trimester, second to third trimester till delivery. These pregnancy changes will lead to proliferation and differentiation of the mammary epithelium. So in another way, it is the preparation of the breast to produce milk to be ready for the second life for the baby. So both lobular and alveolar growth will occur. As we notice, there will be increase in the weight and in the blood supply for these vital structures. Differentiation of the alveoli into mature milk-producing cells, which will require the stimulus of cortisone, prolactin, and insulin. What about risk factors? Risk factors for breast cancer, they are variable. We can depend on that. It's the same risk factors for non-pregnant ladies. Because of that, we have always to concentrate on the risk factors. Some of them are changeable, you can modify, others are non-modifiable. But in general, we have to take care for these risk factors. That might include age, the sex as a female, occupation, especially when there is an exposure to radiation, age of menarche, age at the first live birth should be less than 30, age of menopause, breast cancer also among first degree relatives, the family history, which is an important thing that we always talking about, especially when we are talking about the first degree relatives rather than the others. Other risk factors, breast biopsies and the history of breast cancer. When there is any breast cancer within the same patient, we have to take care either in the same breast or other breast. We should concentrate on her more and more during investigation and during follow-up for the pregnancy. Exposure to radiation, important thing, and it is directly related to the breast cancer in pregnant and non-pregnant ladies, the race, and also we talk about obesity and physical inactivity. So this is one of the modifiable risk factors. Always we are talking about the obesity. Try to stop obesity because obesity itself, it will increase the risk and might double the risk of breast cancer in our ladies. Now starting our management for the patient, usually starting by that what we call triple assessment. It involves clinical, we are talking about history and physical examination. This is the first part, clinical, history and physical examination. History, we have to concentrate during our history mainly on the risk factors that already we mentioned before and other risk factors. If they are present, we have to take a higher suspicion for malignancy. During examination, we know as a non-pregnant lady, although it is sometimes when we are talking about in the second to third trimester, as we said before, the weight and the high blood perfusion to the breast will lead to difficulty in diagnosis, especially mainly during examination for those ladies, even if the larger breast masses might be missed at the one stage or another. Then we'll go for the second line for triple assessment, which is the imaging. Imaging, mainly depending on ultrasound and mammography. We will talk a little about that. Those are for diagnosis. Rather than for staging, we are talking about other investigations, which are, some of them are allowed, so others are not, or are not recommended. At the end with the pathology, and this is the tissue core biopsy. So when we are dealing with the triple assessment, we are dealing with a high percentage of clear diagnosis for hair condition. Here regarding the ultrasound, we are talking about breast ultrasound. It's recommended and it's essential for the diagnosis. Mammography also it's recommended for even if she is pregnant, but we have to use the abdominal shielding in order to protect the fetus as possible as we can. Although it is the dose of radiation is very minimal, but we have to take also precautions. What about MRI? Breast MRI is not recommended, especially if there is any need for any contrast type. But what about the staging process? During the staging process, some of investigations, radiological investigations are allowed, like when we are talking about chest X-ray to check for the lungs, let's say, but we have to use abdominal shielding, abdomen and pelvic ultrasound, looking for suspicion of malignancies or metastasis. We can do it with them easily. Other investigations during staging, we using some of them, we can use them frequently in non-pregnant ladies, but in pregnancy, they are not recommended and they are not allowed. Like an example for that, CT scan is not recommended at all. Bone scan or bone isotope scan also not recommended, and PET scan. All these high dose radiation should not be given for the ladies, the pregnant lady. After these investigations, we go to the core, which we said before, which is tissue core biopsy, which is recommended for the pathologist to diagnose, to prove our diagnosis that our patient having hair breast cancer. After that, what's next? An important issue, which is the multidisciplinary team meeting. Multidisciplinary team meeting and their decisions. Multidisciplinary team, it includes breast surgeon, radiologist, oncologist, radiotherapist, histopathologist, and psychotherapist. Here we can clearly see, once we are talking about breast CA in pregnant ladies, who is missed? The obstetrician. Yes, obstetrician is not always present in the multidisciplinary team meeting unless we are talking here with pregnant ladies that we should take clear decisions regarding the life and regarding to continue or not the pregnancy, and regarding the effect of or the possible effects of chemo, radio, or hormonal or targeted therapy on those patients. So we have to put our plan regarding the treatment. The treatment, it depends on the stage of the disease, TNM classification, hormonal status, hormone receptor status, ER and BR, estrogen and progesterone, HER2 receptor status, and gestational age. Because of that, we mentioned before, the obstetrician is an essential part of our MDT meeting. Here, I put in a red color because the patient preference. All our decisions, if the patient refuses, no one can do anything. Because of that, during the multidisciplinary meeting, many decisions, many opinions could be present and discussed. But at the end, the final decision should be clearly discussed with the patient and the patient family. Because at the end, we cannot do anything for the patient if she refuses our decision. So it is a combined decision between the multidisciplinary team meeting people and the patient herself and her family. So treatment plan, it doesn't differ. There's that difference between the treatment plan in pregnant and non-pregnant, except for regarding the fetus and some protocols. So protocols should be as close as possible to non-pregnant women. All the time, first line of treatment is surgery, unless we are talking about stage 4 and highly locally advanced breast cancer in a different way. But in general, the first line of treatment is surgery. Surgery in general, as a mastectomy or breast conserving surgery. Breast conserving surgery, we are trying to use breast conserving surgery most of the time, especially when there is a tumor size is less than 3 centimeters. When there is single lesion clinically and by mammogram, tumor more than 2 centimeters away from the nipple area complex, lesion of lower histological grade, and there is, especially when there is no nodal involvement. In those cases, we go for breast conserving surgery. What about mastectomy? Mastectomy, we might go for mastectomy when there's a different story. We're talking about larger size tumor, multifocal multicentric tumors, retroareolar tumors, or there's a debate about that, whether to perform a central quadrantectomy or to go for mastectomy. But in another way, mastectomy is a little bit better than that. Also higher grade and also poor prognosis types, like when we are talking about triple negative patients, it is preferable to go for mastectomy rather than go for breast conserving surgery. So here, as we see, the first trimester, we can classify the the prognosis and also the management for those pregnant ladies according to the trimester that we catch the disease in this patient, starting by first trimester or second and third trimester. As we see here, the surgery is always the first line of management in both sides, wherever or at what type of stage or what trimester you catch the patient, the surgery is the first line of treatment, unless we are talking about, again, for the fourth stage where there is skin involvement or there's fixation, then we have to go for chemotherapy and other solutions regarding the fetus for abortion or not. So first trimester, we can, after doing surgery, you can wait a second trimester for medical treatment if feasible. And sometimes we might go for discuss the termination if medical treatment is urgently needed, as we said in case of stage 4. What about second and third trimester? Chemotherapy is indicated. Also, there are special type or specification for these types of medications or chemotherapy could be used. And regarding radiotherapy, usually we have to wait after the pregnancy is finished. Types of, let's say now regarding the same slide in more clear way, the breast surgery, yes, it is applied and there is a strong rule for breast surgery during the whole time of pregnancy and after delivery also. Sentinel lymph node biopsy, it is applied. Either we are going for sentinel lymph node or if there is evidence of metastasis, lymph node metastasis, either by FNA or by any other procedure, we might go directly for the MRA, modified radical mastectomy, meaning simple mastectomy and axillary clearance within the same session. Radiotherapy, another story. Radiotherapy is not allowed usually to be given during first, second, or third trimester at all. But after delivery, we can give radiotherapy because of the hazards and the, say, very bad side effects regarding this radiotherapy. We'll talk a little bit about. What about chemotherapy? Chemotherapy during the first trimester, it's not allowed. Because of that, if we are in need to proceed, sometimes we have to terminate the pregnancy and then to continue on chemotherapy in the first trimester. What about second and third trimester? We can use chemotherapy with specific preference for some of these medications. Anti-HER2 therapy, it's not given during pregnancy, only after delivery, and also endocrine therapy, the same. Radiotherapy affects that we mentioned before, that the radiotherapy is not allowed to be given during pregnancy all the time because of the very bad side effects. Mainly, we are talking about the fetus that we are taking care of. So these side effects could include miscarriage at any time of pregnancy, teratogenicity. So teratogenic effect will be clear on the fetus, microcephaly, fetal growth restrictions. Also, we find that the growth of the baby is not following the real standards for the others. Learning difficulties later on. Later on, the fetus of the ladies who already received radiotherapy anyway, they will have those learning difficulties and delayed milestones. Induction of childhood malignancies. Some reported cases talking about childhood malignancies related to radiation exposure of the mother during pregnancy, and also hematological disorders. Now, what about chemotherapy? Chemotherapy classified as class D drugs. They are crossing the placenta, but as we said before, it is contraindicated to be given during the first trimester. Two other causes will be mentioned in the next slide. If we have to give the chemotherapy during pregnancy, it's preferable to use anthracycline-based regimens, are safer. On other options, in some cases, we might go for taxanes groups. The advantage of chemotherapy, found they will reduce the recurrence rate and they will reduce the death rate by specific percentages. Chemotherapy, as we mentioned before, it is the first line of treatment in case of stage 4 that we are talking about, locally advanced breast cancer invading the skin or fixed to the chest wall muscles. In this case, the termination will occur in the first trimester if we talk about. Adverse effects of the chemotherapy, intrauterine growth retardation or restrictions. So the child will not
3 minutes, please.
follow the same level of development like others. Preterm delivery, low birth weight, tachypnea of newborn, transient neonatal leukopenia. So all the side effects that we mentioned before are for the fetus mainly. Special considerations in pregnant ladies, termination of pregnancy. If we have advanced disease with poor prognosis, sometimes we have to go for termination, poor patient condition, and fetal exposure to more than 100 of radiation in the first trimester mainly. What about breastfeeding? Breastfeeding is contraindicated in women on chemotherapy. If the patient is asking to breastfeed her child, sometimes it's allowed at least after 14 days after the last dose. Also, it is contraindicated if on hormonal treatment. What about post-radiation? Post-radiation, if the patient is asking for breastfeeding, usually she will not be able to do that because of the fibrosis that might occur during the radiation exposure.
Now about
the diagnosis of breast cancer in pregnancy represents a unique challenge for the patient and caregivers and the treating physicians, because we mentioned before they are talking about 2 lives here.
also
Several religious, moral, or social issues.
here we are talking about
Termination of pregnancy at some stage in group of patients. So because of that, we have to take care from all these aspects that might affect our patients.
the complex situation of
The breast cancer in pregnancy requires involvement of multidisciplinary team from the phase of management.
all
Breast cancer patients, they should be discussed and decision taken for the treatment by the multidisciplinary team, especially we are talking about the pregnant ladies, to that more and more with the presence of obstetrician. Current guidelines nowadays on this topic rely on limited evidence because just we are taking these from the studies. And thank you.
Thank you, Dr. Hani, for your informative and excellent presentation. Dr. Bassam, Dr. Maisa is ready, as I saw.
Okay, thank you, Dr. Marwan. Thanks for Dr. Kafawin. Now we want to present the last speaker on this session, Dr. Maisa Khader. Dr. Maisa, she wants to present the update in diagnosis and management of hypertensive disorders in pregnancy. Dr. Maisa is a senior obstetric and gyna consultant, currently working in a private sector. She is an associate professor at the Department of Obstetric and Gyna at the School of Medicine. You're welcome, Dr. Maisa, please. Dr. Maisa, your voice is not clear, Dr. Maisa.
Her microphone is muted. Can somebody ask her to unmute it?
Please unmute your microphone, Dr. Khadra. Rah.
Can you hear me now?
Yes, yes.
Okay.
Please.
Good afternoon, everyone. So my talk, thank you, Dr. Bassam. My talk will be about update in the diagnosis and management of hypertensive disorders in pregnancy. Just 1 second. It's not, the screen is not moving with me. Sorry for that.
دكتورة حركي الماوس على السلايد بعدين بعدين حركي بالأسهم.
Okay. So hypertensive diseases in pregnancy, we have 4 categories. We have chronic hypertension with superimposed preeclampsia, gestational hypertension, and then preeclampsia and eclampsia. The major update on hypertensive disorder in pregnancy was in an executive summary by the American College of Obstetrician and Gynecology, which was published in 2013. They made a special task force for hypertension in pregnancy, and they came out with an executive summary. My talk today will be based on that executive summary plus a practice bulletin published in June 2020 about gestational hypertension and preeclampsia. Because of the sake of time, I will just concentrate on these 2 identities. Hypertensive disorder is a leading cause of maternal mortality and morbidity. Preeclampsia complicates around 2 to 8% of pregnancies globally, and it is responsible for 9% of maternal mortality in Asia and Africa. It's also responsible about 26% mortality in Latin America and the Caribbean. The definition of gestational hypertension, which you might all know, it is an elevated blood pressure of 140/90 after 20 weeks of gestation. It's not associated with proteinuria or any systemic symptoms. It is also associated with normalization of blood pressure after pregnancy. It's important to know that 25% of gestational hypertension progress to preeclampsia, and 25% progress to severe gestational hypertension associated with higher maternal and perinatal mortality than mild preeclampsia. Gestational hypertension, we have to have close monitoring, twice weekly blood pressure monitoring, at least 1 visit weekly in office with urine protein assessment, and you have to have a weekly lab assessment of platelet counts and liver enzyme. It is very important to mention that gestational hypertension is not different preeclampsia without severe symptoms. They both have strict surveillance, and actually we are not sure whether they are different identity or it is just a strict nomenclature. They might be the same. We start antihypertensive medication only when blood pressure is more than 160/110. Strict blood test is not recommended for all women, but on individual basis. So you do expectant management for mild disease until 37 weeks of gestation. If you develop severe feature, you deliver after 34 weeks. And it's very important to mention that 50% would develop into PET, and progression is more likely if the diagnosis is made before 30 weeks of gestation. Now we go to preeclampsia. Preeclampsia with and without severe feature. It is a multisystemic disorder of unknown etiology, usually occurring after 20 weeks of gestation. And it's defined by hypertension, proteinuria of more than 300 milligrams per day with +1 proteinuria and diabetic, and edema. Why does preeclampsia occur? It is characterized by abnormal vascular response to placentation, increased systemic vascular resistance, enhanced platelet aggregation, activation of a coagulation system, and endothelial dysfunction. So if we break the traditional breakdown of the syndrome of preeclampsia into maternal syndrome and fetal syndrome. So the effects of the mother are hypertension, proteinuria, and multisystemic dysfunction. On the fetus, growth restriction, oligohydramnios, and abnormal oxygenation. It's of paramount importance to notice that before we used to call it pregnancy-induced hypertension, and it first moved into gestational hypertension and mild severe preeclampsia and eclampsia. Now it moved into preeclampsia with preeclampsia alone or preeclampsia with severe feature. The risk factors pre-preeclampsia are nulliparity, multifetal gestation, preeclampsia in previous pregnancy, chronic hypertension, pre-gestational diabetes, gestational diabetes, thrombophilia, SLE, body mass index of more than 30, antiphospholipid syndrome, maternal age more than 35, kidney disease, assisted reproductive technologies, and obstructive sleep apnea. Preeclampsia is a dynamic process. So we changed the nomenclature was changed from preeclampsia mild and severe into preeclampsia with or without severe symptom because it is a dynamic process and the disease is progressive at different rates. What are the diagnostic criteria for preeclampsia? A blood pressure of 140/90 on 2 occasions 4 hours apart, or blood pressure of 160/110 on 1 occasion. And proteinuria, and the proteinuria as defined before, it is 300 milligram or more per 24-hour urine collection, or on protein creatinine ratio of 0.3 or diabetic of more than 2. What has changed in the absence of proteinuria? So now proteinuria, and that's actually since 2013, proteinuria is not mandatory for the diagnosis of PET. So in order to diagnose PET in the absence of proteinuria, it should be a new onset hypertension with a new onset of any of the following: thrombocytopenia of less than 100,000, creatinine of more than 1.1 milligram per deciliter, impaired liver function, and we mean by this twice than the normal, the presence of pulmonary edema, and the presence of a new onset headache unresponsive to medication and not accounted by any alternative diagnosis or visual symptoms. So when do you say it is a severe preeclampsia? It is severe features of preeclampsia should include any of the following: systolic blood pressure of 160 or higher, or diastolic of 110 or higher on 2 occasions, platelet count less than 100,000, impaired liver function, serum creatinine concentration greater than 1, pulmonary edema, a new onset visual disturbances. And the difference here, before we used to consider IUGR as part of the diagnostic criteria for severe preeclampsia. Since 2013, it's no more considered as part of the diagnosis. Management. Decision for immediate delivery versus expectant management is based upon disease severity, fetal maturity, the maternal condition, fetal condition, and cervical status. In preeclampsia without severe features, we deliver usually at 37 weeks and above. below 37 weeks, we could aim for expectant management until term or maternal fetal indication for delivery. Bed rest is no longer suggested, and we should have serial maternal measurements of blood pressure, the symptoms, the lab, hair weight gain because of edema. We should have serial fetal assessment with non-stress and biophysical profile, serial ultrasound for amniotic fluid volume and growth. In severe preeclampsia, usually above 34 weeks, you should deliver. You could aim for a delay for 48 hours for the aim of dexamethasone for lung maturity, but not more than that. Between 33 to 34. Okay. If I can ask you to mute your microphone. Between 22 and 32 weeks, use antihypertensive medication, steroids, and then we have to really have extensive counseling, especially in extreme prematurity, because we cannot know what will happen with a delay over weeks. And definitely below 22 weeks, we should consider delivery, and expectant management below 22 weeks is not recommended. Having said that, this is based on American guidelines. Each country should have its own guidelines because our rates of survival below 24 weeks is very low. So this number of 22 maybe in Jordan should be 24. So we should not maybe aim for expectant management in severe preeclampsia in Jordan below 24 weeks. Also between 24 weeks to 28 weeks, the survival is good in Jordan, but is not the best. So we have to take it case by case. Eclampsia, it is the new onset of grand mal seizure in the setting of preeclampsia. In the setting of eclampsia, you have to stabilize the mother, control the seizure with Valium, prevent recurrence with magnesium sulfate, and the use of antihypertensive medications to lower blood pressure. We have to assess fetal status, and cesarean section is not always recommended. We could aim for vaginal delivery only if the maternal condition is well controlled, and also if the vaginal delivery could happen in a reasonable time in multigravida with some dilatation. HELP syndrome is another form of severe eclampsia or preeclampsia. It includes hemolysis, elevated liver enzyme, low platelets, may present without hypertension or proteinuria in 10 to 15%. So in the context of hemolysis and elevated liver enzymes and low platelets in the absence of hypertension, it still can be HELP syndrome. Expectant management in HELP is not recommended regarding of the gestational age at diagnosis. And your aim of management in the three entities of severe preeclampsia or preeclampsia and HELP is seizure prophylaxis, IV fluids not to be greater than 150 cc per hour or 1 to 2 cc per kg per hour, strict input and output. And if you started magnesium sulfate, you should be monitoring patellar reflexes, respiratory rate, lungs for pulmonary edema, and serum magnesium level. And we should always have a continuous fetal monitoring. Antihypertensive agents used for agent blood pressure control are the three important ones are lipitalol, hydralazine, and nifedipine. Lipitalol is given IV for a maximum at bolus doses of 10 to 20 milligram. For a maximum dose of a cumulative dose 300 milligram. Hydralazine is given at bolus doses of 5 milligram. To a maximum cumulative dose of 20, and nifedipine is a given dose at 10 to 20 milligram every 20 minutes for a maximum daily dose of 180. Whenever we have severe preeclampsia, eclampsia, or HELP, we should aim to start magnesium sulfate. There was a big trial a long time ago called the MAGPIE trial about magnesium sulfate, and now it is the gold standard use for the prevention of seizure, and it does not really, it's not used as an antihypertensive medication, but it might slightly lower blood pressure. It delays neuromuscular transmission, it decreases smooth muscle contractility, and depresses CNS stability. So it was associated with a better maternal outcome and neonatal outcomes in terms of an ICU admission and maternal morbidity. So what about prevention methods? What can we use in order to prevent recurrence of preeclampsia? There is a lot of talk about different things such as decreased weight loss, exercise, magnesium, zinc supplementation, a lot of things. Most of them were not evidence-based, or the evidence didn't show any benefit. The main one with benefit was low-dose aspirin. It was associated with a 19% reduction of preeclampsia and 16% reduction in fetal and neonatal death. And it should be a low dose in the term of 81 to 100 milligram per deciliter. Higher dose were associated with more maternal morbidity. Thank you.
Thank you, Dr. Maisa, for this excellent presentation. And by the end of this session, I thanks Dr. Saifuddin Saleh, Dr. Maher Maaita, Dr. Maisa Khadra, and Dr. Hani Kafawin. And we want to give a chance for questions. If there is any question for anybody, for the presenters.
I think there are a few questions in the chat. I will just check.
Okay, follow.
ما في الشات؟
ما في. ما في.
chat box كان فيه.
No question.
Is there any question? The chart.
No questions.
I have one question for Dr. Hani Kafawin, if you allow me.
Yes,
please.
Yes, please.
Okay. Dr. Hani, I was lucky to join your at the end of your lecture, and unfortunately last year I have a couple of patients, actually one, currently one, and another one before with breast cancer. I noticed the practice, and I was looking at, so unfortunately I only attended the last part of your lecture. So I can read in your slides that surgery is the mainstay of treatment. But a lot of, one of these patients was 13 weeks and she was having breast cancer in the early stages, and she was giving new adjuvant chemotherapy. So I want your comment on new adjuvant, which is now in pregnancy. So should we give chemotherapy as a new adjuvant before surgery or not? What's your recommendation?
يعطيك العافية دكتورة. regarding هلا اللي فهمته من سؤالك إنه how much weeks the first trimester received new adjuvant chemotherapy.
Yeah.
هلا شوفي دكتورة بالنسبة للنيو adjuvant chemotherapy هلا بالحالة هاي إنه what about the fetus؟ يعني did she terminate the pregnancy or not?
So I have a couple of them. One was 13, she didn't terminate, she continued and received 5 courses of chemotherapy during a pregnancy. And then she was planned for surgery after new adjuvant chemotherapy.
هلا دكتورة بشكل عام احنا بنحكي على المرضى الفيرست ترايمستر. In general we prefer, if we have to give chemotherapy, we prefer for the termination unless the patient and the family they will take and accept the risk on the fetus, whatever the condition it is. Because I mentioned in the complications of the chemotherapy for the fetus later on, regarding all these complications and let's say mental issues and risk of many serious conditions that will affect his life, his future life. Because of that, I think the best thing at that time, if we have to give her chemotherapy at that time, I think termination and to continue the management of surgery. I think Dr. Maher Maaita معانا معلمنا. We discussed many cases with him previously, وصراحة كنا احنا نحاول بعض الحالات نحولها على الدكتور ماهر والزملاء. فممكن دكتور ماهر كمان يعطينا فكرة أفضل شوي.
دكتور هاني سؤالي إنه بشكل عام يعني المريضة اللي عم بحكي عنها كانت when she was diagnosed she was around 13 plus 5, so she was second trimester. So what is the benefit? هذا سؤالي لإلك. What is the benefit of new? She is second trimester. Consider her. I have a new one actually, which is first trimester.
Can I interrupt here? I'm Ambika Anand. I'm one of the oncoplastic surgeons. Is it okay if I interject here? Do you mind if I?
Oh, please do.
Okay, so thank you very much. I don't speak Arabic, so I didn't understand some of the things that you were going, but the gist of it was breast cancer in pregnancy. So I actually now work in Doha, but I'm UK trained. Thank you very much. It was a great talk. And pregnancy-associated breast cancer is not just pregnancy only. It's also over the lactational period. Many of these women develop breast cancer, but they do have to be dealt with differently. And absolutely agree, it has to be multidisciplinary. It has to be very much patient-centered, and it has to be discussed very much individualized treatment. No one treatment fits all. So one of the things for your patient, Dr. Maisa, you said, second trimester and third trimester, chemotherapy is fairly safe. Not all chemotherapy, certain chemotherapies are safe.
Yes.
Okay, so oncologists will be the best judge to tell you which chemotherapy are safe. If you can get the patient to the full term, that would be the best way to do. First trimester teratogenic effect with chemotherapy is immense. So chemotherapy has no role. So that is where the very difficult situation and where the cultural issues, because termination of pregnancy. So I'll just share a patient with you. I had a lovely, intelligent Somalian patient. This was about almost 18 months or 2 years ago. She was finished lactating and she had noticed a lump, and then it was considered to be lactational galactosile, and they didn't investigate, and she got pregnant again. And then this one, lo and behold, this was in a private sector in Qatar, in Doha, landed up being malignant. And then, so by this time, she was already 16 weeks or 18 weeks, okay? Oh no, she was already 20 weeks. She was already 20 weeks. And she was like adamant, I just want you to terminate. And only 20 weeks. It's a difficult situation. So we had to discuss it in the MDT. The MDT decision was that the chemotherapy is fairly safe. And she already has 5 children before. And she was like, okay. So I got hold of, like you said, patient-centered. You have to take patient into consideration. If patient says, no, there's nothing you can do. What I do in this situation is get another colleague to speak to them. And then they said, okay, give me all your details. We want to send the notes, and the reports to Canada. The Canadians said the same thing. Neoadjuvant chemotherapy, take her to term, and then let her have surgery. And she's a lovely, lovely child now. I've seen her. She's brought the pictures and come back and shown it to me. So it's very much an individualized treatment. You won't say that surgery is the first option. And then when it's question of termination, sometimes you have a precious baby in first trimester, and it's difficult. And then another issue is, if women who have breast cancer and then later on want to become pregnant, what do you tell them? These are so many complex issues, but I'm so glad you included me in this talk. And I have to thank Dr. Dhaka for sending me the link so that I can join. It's one of those subjects that I'm very, very, very passionate about. And there is quite a lot of literature available now. And safety, thanks to all the oncologists who are participating here. Hats off to you guys. You have made things so much better now for patients. Survival benefit is definitely better, much more tolerant. So thank you very much.
Thank you. Thank you. Is there another question or clarification?
Yeah, I think there is another question in the chat.
Please go ahead.
It's for Dr. Maher. I'm just reading it from the chat. Is there any difference in maternal mortality rate among medically indicated or those patients who prefer cesarean section? Is there any difference in mortality?
No, what we found is that 70 or plus of maternal deaths were associated with cesarean sections, i.e. they underwent cesarean section and they had complications of the cesarean sections, maybe anesthesia related, bleeding, a number of issues. But what happened, it's associated with cesarean section. That's why we concluded at the end that we should not take cesarean section lightly. We should be careful. We should promote the fact that we should try and work on reducing cesarean section rate in Jordan. Do you know in Brazil, for example, the cesarean section rate is almost 80%. In the UK, when I started training, it was 15%. Now 30% is acceptable. In Jordan, across the board, it's probably around 40% in different places. Obviously, the tertiary hospitals will have higher rate of cesarean section because they get referrals and they get preterm deliveries and things like that. So the message is that cesarean section is associated with maternal mortality in Jordan. This is a fact. And that's why we should take cesarean section decision carefully. And we should work on reducing the cesarean section rate in Jordan in all sectors, private, public, universities, military, all health sectors in Jordan should have policies to reduce the rate of cesarean section, because it is, we found 70% of maternal deaths were associated with cesarean section.
Okay, thank you.
Thank you. Thank you, Dr. Maher. By the end of this session, I want to conclude an important fact that we have now in Jordan a maternal mortality registry, which is a national-based registry for the first time. And inshallah, as Dr. Maher said, that our maternal mortality ratio is 29.8 per 100,000 live births. And this is the first time. Hope that to achieve and to ensure healthy lives for our women. Thank you very much. And inshallah, the third session will be start at 14:30 after the prayer. See you on sharp for the third session on 14.
I will check the chat.
يعني الساعة 2:30. Dr. Soha, if you have notes.
No, thank you. Just another note, I will just say this in Arabic for the people who are joining us. I think now they're around 30. As I said in the morning, there was a glitch with the system. We don't know why it happened. Some people had the wrong Zoom link. Please make sure that everybody gets the right one, which is apparently this one. بليز يا جماعه لو سمحتوا انه اللي بيقدر قد ما يقدر انه ينشر اللينك تبع الزوم هذا الصحيح، واذا حدا عنده اي مشكله بيقدروا يروحوا على الموقع، في واتساب مسجز على طول تبعت لنا وبنصلح الموضوع. اي شيء تكنيكال او شيء ديفيكلت على طول انستنتلي بنجاوب. وثانك يو فور ناو. شكرا كثير دكتور بسام وشكرا لكم. It was really a good and great session.